So when we are searching our evidence, and this kind of starts to bleed into how we appraise the evidence as well, and how we determine the level of evidence, we want to think about bias control. So bias is really the fact that could what is happening that we see in the experiment be more about random error, be more about the research is biased or the subject's bias than it is about the actual effect. And so usually the experimental designs have the most bias control. And then when we start to get down on the scale, we go to more least bias controls, which are things like case reports or anecdotal evidence. So because I've seen it work with my patients in the past, things like that. So over on this end, we have our randomized controlled trials, single system designs or systematic reviews. So if you see these words, usually that means more bias control, but it's still up to you to look. We'll talk more about that later. Over at this end, we have your own case files, your medical files, so your electronic medical records, case reports, summaries, narratives, things like that. And then to move from this end to that end, usually designs start to lack or start to lose one or more of these criteria. So do they use randomization techniques? So are they randomly putting individuals into groups? Do they use more than one group for comparison? Either two experimental groups? Do they have a control? Do they maybe have a sham, which we talked about with pain when we talked about placebo effects? Controlled experimental manipulation of the subject. So is there really a specific protocol on how this group gets the treatment and how that group doesn't get the treatment, but everything else is the same and done the same? Is it measured at the patient-client level? So if we start to really be thinking about, again, healthy tissue instead of injured tissue, or animal studies versus non-animal studies. And then, is there a systematic method for collecting and analyze the information? Again, do the researchers follow the same steps for how they are measuring temperature or range of motion or functional activity level? Do they follow the same steps with every patient every time? In these quasi-experimentals, they might be lacking, again, one or more of these things. And then we get to the non-experimental designs. Those would be more like our observational studies, again, physiological studies that maybe aren't at the patient-client level. So what type of evidence is out there? Again, over here we have tradition and expertise. That's really important. We want to keep that in mind. But ideally, we find more things over on this side of things. So research, taking theory and potentially working it into these studies. Laboratory research, observational research, again, maybe not at the patient level, so it's not our best evidence, but it's something that's available to us. Then we have case studies looking at single patients or maybe a couple of patients. Sometimes that's called a case series, where basically kind of just following that patient or those patients and what treatments that individual clinician decided to use for them, how they responded to that intervention. There's no control subjects. There's no indication of kind of the relative value of these various interventions compared to something else. Okay. Cohort studies. This is usually a group of patients that are followed over time. So the outcomes are usually measured prior to the intervention and then periodically kind of followed up with following the intervention. So again, not a lot of really manipulation of the subjects, more of just kind of following what happens. Cross-sectional studies are, again, a group of patients. They're examined at a single time during or following an intervention, concerning kind of their current or their past history regarding the effects of the intervention and outcomes of interest. So we don't get the pre and post necessarily, but we just got to kind of get this one snapshot in time. And then our case control study. So now we do have two groups, okay? They're selected on the basis of either maybe potentially having or not having the outcome or the intervention or the condition, whatever it might be, whatever that interest is. And then we're examining kind of what happens. So again, we're not really manipulating it. We didn't determine that this group used ICE and this group used ultrasound. We're just saying, okay, these people did use ICE and these people did use ultrasound. What differences do we maybe see between those two groups? We're also usually not stipulating very well the parameters. So could these people say they used ICE and they really put it on for 5 minutes once? You know, things like that. Then our clinical trial research, which is a subcategory of the case-controlled study, that's the cross between kind of the two. So it's a little observational. The patients are studied while receiving kind of normal clinical treatment, but then it also has a little bit of a laboratory component in that a lot of times there is a prospective control group. So not only do we look for the observation of the current patients, but we do then kind of look, okay, what if someone didn't have this condition and what would that entail? And then we have kind of usually which starts to get us closer to our upper level evidence, clinical or controlled trials, where a specific medical intervention is done on the patient with a specific injury or disease, usually non-randomized though. So again, we're not controlling that they have the condition or not, or that they have this intervention or not, but we then do control everything else. And then our randomized clinical trials are, we randomly put people into groups. It has the most bias control. Usually what we try to see for looking at the effectiveness of medical treatments. So here's that on kind of a hierarchy scale. So again, when we talk about giving a level of evidence to something, this is one scale. There's several scales and you'll see a couple of different ones in the, this presentation. But this is one scale, so the hierarchy of evidence. So systematic reviews of randomly controlled trials are our highest level, our level 1A, and it goes all the way down to level 5. So when you're doing your project, part of your job is going to be, of the articles you're reading, you're going to give various scores to it. Hierarchy should be one of them. So as we continue to look at the evidence that's out there, and again, kind of thinking about a little bit of appraisal, but still while we're searching too, to making sure that we're searching for the right type of stuff, you have to have kind of some background on what a scientific paper consists of. And so based on kind of that scale of evidence that we just talked about, we can then put those into kind of characteristics. So a study can be either quantitative or qualitative. So does it deal with numbers or does it deal more with like feelings or thoughts? So this might be interviewing patients. This might be getting standard numbers about patients. The design format. So again, is it experimental, quasi-experimental, or non-experimental? So thinking about our bias control. So purposeful manipulation. We also have manipulation but no random assignment with the quasi. Non-experimentals are usually observational, no real manipulation. We're just kind of seeing what happens. May only have one group, might have two groups. The number of groups. So again, is one group of subjects available for study, or are there more than one and we can use more statistical analysis to compare? The degree of control. That goes by, again, the experimental, quasi-experimental, or non-experimental. Is it cross-sectional? So again, the data collected one point in the story, or is it longitudinal? Do we see a pre? Do we see a during? Do we see post? Do we get maybe a month follow-up, several years follow-up? It kind of depends. And then is it retrospective or prospective? So retrospective is historical data. So if you had a question or wanted to do research on how all ankle sprains at Gustavus have been treated from 1997 to 2017, and you would do that research. That's all retrospective. Prospective would be like, I am starting now, and I'm going to look to the future and see how we, for the next 2 years, treat ankle sprains. Another thing to keep in mind, and we've talked a little bit about this already, is the method of control. So again, how do we control some of that bias? And how do we manipulate our subjects in order to make sure that everything is done the same, and the only possible, ideally, difference is the intervention that the individual got. So again, do we have, excuse me, 2 or more groups to compare? Is there random assignment? Have we tried to what we call blind both the subjects and the researcher? So if you know that you're in the control group, again, this has a little bit of placebo effect to it, right? Like, are you going to get better? Are you not going to get better because you know you're in control? So you know you're not getting the intervention. Same with the investigator. If you really want to, you're spending all this time doing this research, if it's something, especially something subjective that the researcher has to measure. So for example, I did my master's thesis, I had to watch these videos, and then I had a scaling system, like a scale sheet that said, okay, when they land from a jump, their knee is in 20 degrees of valgus or more. And I had tools that helped me, but some of these things were subjective. Do they land with their feet shoulder width apart? Things like that. If I really knew what group that subject was in, could I potentially manipulate my results because I really think that this is good research and that there should be a difference? Ideally, I don't know what group, and so I didn't. I had someone else assign the groups, and I just evaluated the data. Is there protocols, again, for how everything is done? And is that the same from the control and the intervention groups, and the only difference is the intervention? Stable environments for the conditions. Complete, sufficient follow-up. So it does no good if we're following ACL surgery patients and we're trying to look at return to play and we stop at 3 months. Because not everyone gets back in 3 months. Really, ideally, we go 2 years out and see what they're really feeling like at that time. So is there adequate time? So some of the terms that you should be familiar with. We've already talked about randomization, blinding, independent variable, right? That's what is being manipulated to produce your change. Dependent variable is the outcome of interest. So this would be ICE versus ultrasound. This would be on pain levels or on return to play, so time to return to play. Okay, so this is what is being studied. Reliability and validity. So reliability is, are the results of the test or the measure identical or closely similar each time it's conducted? So how much can we reproduce the test each time? And we have inter-rater reliability or intra. So inter is between different people. So if you had people helping you, let's say you're measuring range of motion and you're using a goniometer, you know that different people will use that goniometer very differently. So it doesn't have great inter-rater reliability. Intra-rater would be from time to time. So same person, different time. So if I measure them before the intervention and after the intervention, how reliable is my measurement of that range of motion? And then validity is how able is this test or this scale that we're using, how able is that to capture what is intended to be captured? So how well a test or intervention does what it's supposed to do. So if we're saying that we're going to measure pain, how well does pain scale really measure pain? And so all that's usually done ideally by someone else. You use someone else's protocol, someone else's scale. Patient-oriented outcomes should have reliability and validity measures to them, right? All that's really important. Next 2 slides are some various stat terms that are important that might help you find the results that you need to know for your patient. I'm actually not going to spend a lot of time going through these. You can read over these. I have some additional videos up on Moodle that kind of break down a lot of these different concepts. And so if there's ones that you don't feel the most familiar with and you're coming upon them when you're reading an article, go back and watch those videos and see what that term means and if that term's important for you in your research and your evidence for your patient. So again, just also understanding that different types of studies, so going back to your clinical question, are going to have very different types of stat terms in it that you need to pay attention to. So like I said, we're going to be focusing on therapy. Things with therapy might be numbers needed to treat. So if we're going to intervene, say we're going to do preventative ACL treatments, right? Or ACL preventative exercises. How many patients need to ideally be, based on research, be exposed to those exercises for us to save one ACL tear? That's what numbers needed to treat would mean. Effect size might be something that we see in therapy. We won't see things like sensitivity and specificity in therapy. That's going to be up in diagnosis, right? You've talked about that. Positive and negative likelihood ratios and things like that in your diagnosis in techniques class. We're going to see more things like confidence interval and effect size, numbers needed to treat, things like that. So other type of evidence out there, again, getting away from maybe our randomized controlled experimental designs and quasi-experimental designs, clinical practice guidelines. So this is not a fixed protocol. These are things that, again, based on research, organizations have put together. And so our position statements might be a clinical practice guideline, and they help us make the most appropriate decisions for our patients. But again, we got to keep our patient in mind. And is this the newest evidence, right? These things get written and then maybe within 1 year, 2 years, they're out of date. So what can we then, through a search, add to it? Critically appraised topics, again, are good sources, but realize that they're really a small scope. It'd be like using one of your projects to then make all clinical decisions about the use of a modality. We know that's not true because you're using a very small scope, but it can give you some indications of what's out there, and it's based on a clinical question. A critically appraised paper is a little bit different. It's not based on a clinical question. It summarizes the evidence in a single research paper. So it's maybe giving you just an evidence summary of that research paper. But keep in mind that nothing is perfect. So best thing you can do is think about, are these studies performed and reported well? So are the terms I need to know there? Did I see randomization? Did I see blinding? Were those protocols in place? Okay, so did they report all those things so I know that? If they don't report it, you don't know if it happened or not. Can we estimate the likelihood that the results are valid? Okay, and it means what we think it means. Okay, if there's conflicting results, that might be due to the validity of the design, not necessarily that, yeah, ultrasound doesn't do what we think it does. It might be the study. We got to take negative randomized control trials, so RCTs, not RTCs, with a grain of salt. So even if they say ultrasound not effective in this study, well, was the intervention itself not effective, or was it not effective as it was applied? That's all that can say. Was it not effective with that tissue? Was it not effective because of the parameters they used? Was it not effective because of how they were measuring? Maybe they were measuring pain, and this shouldn't affect pain, or doesn't affect pain, but it can affect cell permeability, which could affect healing. You know, it's not necessarily that the intervention is always ineffective. It just means as they applied the intervention, it was not effective. And so again, you understanding your patient, understanding the healing process, understanding the theory behind these modalities becomes really important when you read this evidence.